Dr. Nusbaum received his degree in medicine from Albany Medical College. He has a PhD from MIT, and his thesis was the behavior of ultra high molecular weight polyethylene in artificial human joints. And he also has an MBA from UConn. So we're really privileged to have you here with us today to discuss opiate use disorder in pregnancy. So I'll turn it over to you.
Okay. All right. So what we're going to talk, I don't know exactly what the title is, but let's start with, if you have questions, just ask as we're going. So keep yourselves muted, but if you have a question, just unmute and ask. I think that will be the most beneficial for folks. Secondly, I forgot what the actual title is, but I think the title was very, very broad. So we're just going to basically talk about opiate use disorder in pregnancy. Can you guys see the slide? Yeah? Okay. So let's go forward. Okay, so what I've done is put together some information based on what's in the literature. So this is from the NIH. And from July 2017. So this is the kind of stuff we're dealing with. So they said, this is from NIH, fluctuating levels of opioids in the mother may expose the fetus to repeated periods of withdrawal, which can harm placental function. I don't know what they based it on, but that's what they said. And obviously there's increased risk of neonatal abstinence syndrome, growth restriction in utero, preterm labor, fetal convulsions, and intrauterine fetal death. So this, again, NIH 2017. So it sounds pretty grim. There we go. So we try to dose for pregnant patients. And we know from the pharmacokinetics and studies of patients that pregnancy often requires increased doses of methadone. So, and again, this is from the Canadian Journal of Hospital Pharmacology. So the conclusion of their study was, although it is known that methadone pharmacokinetics is altered by pregnancy, there is insufficient evidence to guide dose adjustments. So basically what we do in terms of dose adjustment for pregnancy is exactly what we do for dose adjustment for any of our patients. We rely on symptoms of withdrawal. We rely on symptoms of cravings. So that makes it a little bit easier because you're all familiar with what we do with our patients. Okay, this is from FACOG. This is 2017 also. FACOG is the American College of Obstetricians and Gynecologists. And they kind of reinforced what we just told you from NIH. So there is a potential small increase of risk of birth defects, but chronic untreated opioid results in lack of prenatal care. Okay, that makes sense. Increased risk of growth restriction, increased risk of abruption, which is when the placenta tears away from the side of the uterus, increased risk of fetal death in utero, increased risk of preterm labor. And again, for any of our patients, pregnant or not, using opiate use disorder can lead to high-risk activities such as prostitution, sex for drugs, increased criminal activity, violence, and custody issues. Again, this is all sounding pretty grim. So again, ACOG committee opinion just saying that withdrawal or tapers lead to high risk or relapse. This is something that we all know from dealing with our patients. Unintended pregnancy in women with substance use disorder is 80%, as compared to the regular population where it's probably about 25%. This is from Protecting Our Infants Act. So this is the feds. Health and Human Services required to review activities related to prenatal exposure and neonatal abstinence syndrome, treatment of opiate use disorder, prevention of NAS, research in NAS. It's now also called NOWS, which is neonatal opiate withdrawal syndrome. So you may see that. And also, excuse me, postpartum depression. That's something that you counselors are going to be dealing with all the time in terms of any of our pregnant patients. Even if everything goes perfectly well, but they wind up having issues with custody, that certainly is going to result in postpartum depression. Okay. All right, so this is from the Society of Maternal Fetal Medicine. The journal is the American Journal of Obstetrics and Gynecology, September 2016. And the title of the paper was Detoxification from Opiate Drugs During Pregnancy. So again, this is what we saw from NIH, what we saw from ACOG: increased risk of stillbirth, fetal distress, premature labor. All these statements are based on two papers, one from 1973 and another from 1975, and these are basically case studies. So in this paper from the Society of Maternal Fetal Medicine, they looked at, what's that? Does someone have a question or I just forgot to mute? Okay. So they looked at 301 patients over 5 years. And this study was done at the department, the MFM department at the University of Tennessee Medical Center in Knoxville. So they divided the patients into 4 groups. So group 1, 108 patients. These patients were incarcerated. And in that particular prison, they had no methadone, no Suboxone, no nothing. So these patients had an acute detox. Group 2, 23 patients, were on a buprenorphine detox that went over 5 to 8 days with intense behavioral health treatment. Group 3, also a rapid detox with bup, but no follow-up treatment. And then the final group was a slower detox using buprenorphine that went over 8 to 16 weeks with intense behavioral health treatment. So the results are kind of interesting. So here are the results. As compared to the disaster that I outlined much earlier, they found no adverse effects. No premature rupture of membranes, no preterm labor, neonatal intensive care unit admissions in group 1. And again, group 1 was the group that was imprisoned with no detox other than a rapid detox. So in group 1, the NICU admissions, 30%. Group 2, 22%. Again, group 2 was buprenorphine detox with intense behavioral therapy. Group 3, another detox with buprenorphine. And group 4 was the slower detox. Now, the only difference between group 2 and group 3 is group 3 did not have any behavioral intervention. So additional studies. So this wasn't part of that paper, which was in the American Journal of Obstetrics and Gynecology, but they did cite additional studies. So you can actually go look these up if you so desire. But you can see there's a list here of 5 different studies that were done over, it looks as long as 12 years. But the main thing that they found after all those other patients, this was another total of 300 patients, no fetal death in utero, no preterm deliveries. And again, no adverse effects. One of the issues they talked about in the protecting our babies thing from, where is it? The Protecting Our Infants Act was the concern about neonatal abstinence syndrome, again, now called neonatal opiate withdrawal syndrome. So Yale did a program to see what they could do with the existing programs in terms of taking care of newborns to moms who are using opiates. And so what they did is they decreased stimulation. So low light, no TV, decreased sounds. The babies were room with the moms, on-demand feeding, console if crying. And so they kind of called this sleep, eat, console. They reduced NICU, time in NICU by 50% just by doing those things. Okay, look, this is obviously a shorter thing. All right, so the conclusions of all this, because I know we all worry about pregnant patients, and because of all these concerns that I showed in the very beginning about preterm labor and fetal death, and it will cause major issues for the mom, for the baby. The other studies don't support that. So again, we dose symptomatically. We don't have to do anything different because of pregnancy, other than what we normally do in terms of symptoms of withdrawal or symptoms of craving. We saw also in that study of the 4 groups that counseling really made a difference. The one group that detoxed, that did not have counseling, had much higher admissions to NICU. And the final thing is that we can reassure our patients, and this is important because so many moms worry about this, that the benefit from methadone maintenance or from medication-assisted therapy is highly beneficial, and that the impact on their babies is going to be minimized by doing things such as what they're doing at Yale. Oh yeah, the other thing is that we've also found that the neonatal abstinence syndrome, or again, now known as NOWS, that there is no real consistent pattern between the amount of methadone or buprenorphine the mother is on versus whether the baby will have neonatal abstinence syndrome and the duration of time in NICU. All right, so I think that should at least be able to reassure counselors and to reassure our patients that methadone, buprenorphine treatment for opiate use disorder is a highly effective method, that the effect on babies is minimal, that we were not going to be hurting their babies if they are withdrawing, that we can safely do all the things that we normally do for any patient, whether they're pregnant or not, in terms of dose reductions or dose increases, and proceed in a very logical fashion. I think that's it. It is it. Okay. Questions? Not even one? Okay.
Just point out, Dr. Nusbaum, this is Christina, just reminding everybody, and you may have touched upon this already, that all the sites do have the pregnancy coordinators and the pregnancy program that
No, I didn't,
cover
but
all
thank you.
those areas. Yeah, and I'll look at these slides again too, just to make sure, or the people that are running the pregnancy program at this point could do that too, is just look through it just to make sure that we have that updated. We probably do need to make some updates at this point. But,
Right.
we do have a really good program, the 12-week program. So hopefully when you have pregnant clients, they're involved in that program, and that all the staff are up to date about what we have and how that process works. So I just wanted to remind everybody of that.
Yeah, thank you, Christina. That's really an important offering that we have for patients. But I think this will give the counselors and the folks in that program more reassurance that this really, really works well for moms and for babies.
Dr. Nusbaum, what about other MAT options for pregnant? Is this like the kind of gold standard, or is if methadone for whatever reason isn't, they don't want it, or there's other contraindications?
Well, I mean, the only other one that's going to work, it will be buprenorphine. Abstinence, as you well know from taking care of patients who have opiate use disorder, not using is really not a good move. People cannot be successful. They're putting themselves at tremendous risk. Obviously, the risk of overdose and all the other things that go with opiate use disorder. So naltrexone doesn't work. The only things that are shown to be beneficial are what we normally do, which again is methadone or buprenorphine in its various forms.
Dr. Nusbaum, can a patient taper off while they're pregnant?
Yeah, they can. Again, that's what the point I was trying to make is that contrary to all the things that we've been told, it doesn't really put the pregnancy at risk. The only thing that's going to put the pregnancy at risk is the mom using again. And obviously, as we tell all patients who are trying to taper off of methadone, pregnant or not, tapering is a dangerous move because this is a chronic relapsing disease. If you're not on methadone, you're not on buprenorphine, you're very, very likely to relapse. And again, the most likely time to overdose and kill yourself is with a relapse. So I would strongly discourage any woman from doing it, for that matter, any patient at all, male or female, because of the risks involved in overdose. But a woman can safely do it and not put her pregnancy at risk.
Thank you.
You're welcome.
Has that evolved, Dr. Nusbaum, over? I was reading something recently about Suboxone and I don't know if it was a few years old, but it was essentially saying that the goal is, just a couple of years and shouldn't be long term. Has that position of kind of it's the safest, best method, has that evolved kind of over the past decade or so as the standard?
With regard to, I think so. I mean, if you look, at our modern understanding of opiate use disorder, we characterize it as a chronic relapsing disease, as a chronic disease of the brain. And we've seen it in experience. How many times have we ever had a patient overdose and die who has left the program? A significant number. And again, the same is true for other addictions. For someone who has an alcohol use disorder, and hasn't had a drink in 25 years, they don't say, I'm all good, because they know they're one drink away from failure. I mean, it's the same concept as a chronic disease. So you may find there may be some patients who, for the reason that they were using opiates was self-treatment for some psychiatric condition. So there may be some who can safely come off, but only if that psychiatric condition has been dealt with. But I think for the most part, not being on methadone or buprenorphine is dangerous.
Are you seeing many requests come through for split doses for pregnant women?
We may. I mean, you know, women believe, or some believe that that's going to be a benefit. But again, we have to apply exactly the same standards that we use for any patient. Just because you're pregnant doesn't make you necessarily a rapid metabolizer. So if a patient says that they need that, that's fine. Let's do the appropriate test. I guess if there are no more questions, but certainly for anyone who has a pregnant patient who wants to discuss anything, I'd be happy to do that. So we don't have to have a grand rounds or a special meeting, but we can set something up for any individual patient who's pregnant.
All right, well, thank you very much, Dr. Nusbaum. That was fantastic. If there's no more questions, I guess we'll close out.
Okay, but again, if there are questions going forward, please call. I mean, you know, having spent 20 years delivering babies, I have some sense of how this all works.
Thank you, Dr. Nusbaum.
Thank you,
You're welcome.
Dr. Nussbaum.
Thank
Okay.
you.
you.